Before we talk about surgery, let us talk about everything that comes before it. Because here is the reality that most people with knee arthritis are not told clearly enough, early enough, or specifically enough to act on it. Surgery is not the inevitable destination of a knee arthritis diagnosis. For the majority of adults with knee arthritis, even those with significant pain, significant functional limitation, and significant radiographic joint changes, the evidence-based non-surgical treatments that exist today are capable of producing meaningful, sustained improvements in pain and function that delay or entirely eliminate the need for surgical intervention. The problem is not that these treatments do not exist. The problem is that most people with knee arthritis have never received them in their complete, optimally combined form. They have received one or two components, perhaps a prescription for an anti-inflammatory medication, perhaps a brief reference to physical therapy, without the comprehensive, coordinated application of the full evidence-based toolkit that orthopedic research and rehabilitation medicine have built over the past 3 decades. Today I am going to give you that complete toolkit. I am going to walk you through the most effective non-surgical treatments for knee arthritis, not as a list of options to choose between, but as an integrated program whose components work together to address the multiple dimensions of knee arthritis simultaneously. The pain dimension, the mechanical dimension, the inflammatory dimension, the neuromuscular dimension, the psychological dimension, because knee arthritis is not a single-dimensional problem, and the most effective non-surgical treatment is not a single-dimensional solution. This video is for you if you have been told you have knee arthritis, and you want to know what the evidence-based non-surgical path forward actually looks like. It is for you if you have been told surgery is something to consider, and you want to exhaust every evidence-based alternative first. And it is for you if you have been managing knee arthritis for years with inadequate results, and you suspect correctly that there are interventions you have not yet tried that could make a real difference. If you want evidence-based guidance for managing joint health and arthritis without surgery, subscribe to this channel right now. We create this content specifically for adults who want the complete picture. Hit subscribe. Let us begin with the framework, because understanding why these treatments work and how they work together is what transforms a list of recommendations into a coherent management strategy. Knee arthritis, specifically knee osteoarthritis, is a disease of the entire joint organ. The cartilage degeneration is the most discussed component, but osteoarthritis simultaneously involves the subchondral bone, the synovial membrane, whose inflammation amplifies pain and accelerates cartilage damage, the periarticular muscles, whose strength and coordination determine how mechanical forces are distributed across the joint capsule, and periarticular soft tissues, whose tightness restricts range of motion, and the central nervous system, the pain processing pathways that determine how loudly the joint signals are perceived and how broadly they are felt. Effective non-surgical treatment addresses as many of these components simultaneously as possible. The first and most evidence-supported non-surgical treatment for knee arthritis is therapeutic exercise, specifically the combination of muscle strengthening, aerobic conditioning, and neuromuscular training that addresses the mechanical, metabolic, and neurological dimensions of knee joint pathology simultaneously. Strengthening the quadriceps reduces the knee joint contact force per step by increasing the muscle's capacity to absorb mechanical loading. Strengthening the hip abductors reduces the knee adduction moment, the rotational force that concentrates load on the medial compartment. Neuromuscular training improves proprioception and dynamic joint stability, reducing the frequency of sudden malalignment events that produce concentrated cartilage damage. And aerobic exercise, walking, cycling, swimming, stimulates the synovial fluid circulation that nourishes cartilage and reduces systemic inflammation. The Cochrane Database of Systematic Reviews has conducted multiple meta-analyses of exercise therapy for knee osteoarthritis and consistently found that land-based exercise produces clinically meaningful reductions in pain and improvements in physical function, with effect sizes comparable to those of NSAID medications. The effect is dose-dependent and duration-dependent. The benefits accumulate with consistent practice over months and years and diminish when exercise is discontinued, which is why exercise is a lifestyle intervention rather than a course of treatment. The second most evidence-supported non-surgical treatment is weight management. Every kilogram of body weight reduction produces a 4 kilogram reduction in the cumulative knee joint load over a mile of walking. A 10% reduction in body weight in an adult with knee arthritis produces reductions in knee joint contact force equivalent to the load reduction achieved by some surgical procedures. Alongside the anti-inflammatory benefits of reduced adipose tissue-derived inflammatory cytokines, including leptin, interleukin-6, and tumor necrosis factor alpha. Research published in the journal Arthritis and Rheumatism found that for every pound of weight loss, there was a 4-pound reduction in knee joint load per step. The combination of weight loss and exercise produces synergistic improvements that exceed the benefits of either intervention alone. The IDEA trial published in JAMA found that the combination of diet-induced weight loss plus exercise produced significantly greater improvements in pain, function, and mobility than either diet alone or exercise alone in adults with knee osteoarthritis. The third non-surgical treatment is physical therapy, and the distinction between generic exercise instruction and specific, individualized physical therapy for knee arthritis is clinically important. A skilled physical therapist performs a specific biomechanical assessment that identifies the individual's unique pattern of muscle weakness, movement dysfunction, joint restriction, and neuromuscular deficit and designs a treatment program specifically targeting these findings. Research has documented that the combination of manual therapy plus exercise produces superior outcomes to exercise alone in knee osteoarthritis, with the manual therapy component providing improvements in joint range of motion and reductions in joint line tenderness that exercise alone does not achieve. Patellar taping that corrects patellar tracking and reduces patellofemoral contact stress has documented effectiveness for patellofemoral knee pain in clinical trials. Gait retraining, which we discussed in detail in our 3 mistakes video, is a specific component of advanced physical therapy for knee arthritis that addresses the biomechanical errors in walking pattern that concentrate load on damaged cartilage. Research published in the Journal of Biomechanics documented that gait retraining produces significant reductions in the knee abduction moment, the most clinically important mechanical predictor of medial compartment osteoarthritis progression, within 6 to 8 weeks of structured practice. Before we continue, here is a pause for you. Have you had a formal physical therapy assessment for your knee arthritis, one that included a specific biomechanical analysis of your gait and movement patterns? Or has your treatment been limited to medication and general advice? Drop a comment below right now and tell us. The distinction between these two experiences is one of the most important practical differences in outcomes for adults with knee arthritis. We read every comment. The fourth non-surgical treatment is bracing and orthotics. Unloader braces for medial compartment knee osteoarthritis are specifically designed to shift the mechanical load from the more severely damaged medial compartment to the relatively preserved lateral compartment by applying a valgus force to the knee that reduces the abduction moment. Multiple randomized controlled trials have documented that unloader bracing produces significant reductions in medial knee pain and significant improvements in walking speed and stair climbing function. Laterally wedged insoles provide a lower-cost alternative that shifts the ground reaction force vector in ways that reduce medial compartment contact stress and improve knee alignment during gait. The fifth non-surgical treatment is topical and oral pharmacological management. Topical NSAIDs, specifically topical diclofenac in gel form, have demonstrated equivalent efficacy to oral NSAIDs for knee osteoarthritis pain in randomized, controlled trials, with substantially lower rates of the cardiovascular, gastrointestinal, and renal side effects we discussed in our NSAID video. Current clinical guidelines from the American College of Rheumatology recommend topical NSAIDs as a first-line pharmacological option for knee osteoarthritis, preferred over oral NSAIDs for most patients given the comparable efficacy and superior safety profile. Duloxetine, which works through serotonin norepinephrine reuptake inhibition, has received FDA approval for chronic musculoskeletal pain including knee osteoarthritis based on clinical trial evidence that it produces significant reductions in pain scores through its action on the central sensitization pathways that amplify osteoarthritis pain beyond what the peripheral joint pathology alone produces. For adults whose knee pain has features of central sensitization, widespread distribution beyond the knee joint, pain disproportionate to imaging findings, significant sleep disruption, duloxetine addresses the central nervous system dimension of pain that peripheral anti-inflammatory treatments do not reach. The sixth non-surgical treatment is intra-articular injection therapy. Corticosteroid injections produce rapid and significant reductions in joint pain through powerful anti-inflammatory effects on the synovial membrane, but the duration of benefit averages for 2 to 8 weeks, and the evidence on repeated corticosteroid injections suggests potential for accelerated cartilage loss with frequent use. Current guidelines recommend corticosteroid injections for acute flares rather than as a repeated maintenance treatment. Hyaluronic acid injections, viscosupplementation restore the degraded hyaluronic acid of the osteoarthritic joint fluid with a synthetic preparation that temporarily restores the viscosity and lubrication of the joint. The most consistent evidence supports hyaluronic acid for patients with moderate rather than severe knee osteoarthritis Kellgren-Lawrence grade 2 and 3 in whom the restoration of joint fluid viscoelasticity provides meaningful lubrication and pain reduction. Platelet-rich plasma PRP injections represent the most recent and most rapidly evolving category of intra-articular treatment. PRP is prepared from the patient's own blood by centrifugation to concentrate the platelets and growth factors they contain, including transforming growth factor beta, platelet-derived growth factor, and vascular endothelial growth factor, and injected into the knee joint, where these growth factors potentially stimulate chondrocyte repair activity and reduce synovial inflammation. A systematic review published in the Orthopedic Journal of Sports Medicine found that PRP injections produced significant improvements in pain and function compared to hyaluronic acid injections and corticosteroid injections at 12-month follow-up. The seventh non-surgical treatment category is the nutritional and dietary interventions we have covered comprehensively across this arthritis series. The anti-inflammatory diet, vitamin D3 for VD are mediated cartilage protection, omega-3 fatty acids for resolvin and protectin production, and vitamin K2 for matrix GLA protein carboxylation and cartilage calcification prevention. The biological environment in which the mechanical, pharmacological, and rehabilitative interventions operate is directly determined by the nutritional state of the joint tissue. The quadriceps strengthening program produces greater and faster gains in a joint whose inflammatory cytokine load is suppressed by adequate vitamin D and omega-3 fatty acids. The gait retraining produces more durable neuromuscular improvements in a nervous system whose pain sensitization is moderated by adequate magnesium. And the intra-articular growth factor stimulation of PRP produces more complete chondrocyte responses in a cartilage matrix that has the collagen precursor amino acids and the vitamin K2 mediated structural integrity to respond optimally to that stimulation. The psychological and behavioral dimensions of knee arthritis management deserve explicit treatment as a clinical component because psychological factors are among the strongest predictors of treatment outcome in knee osteoarthritis, independent of radiographic severity and biomechanical factors. Pain catastrophizing, the tendency to magnify the threat value of pain, to ruminate on pain when it occurs, and to feel helpless in the face of pain, is one of the most powerful psychological predictors of poor outcomes in knee arthritis. Research has consistently found that adults with high pain catastrophizing scores show less improvement with both exercise therapy and surgical intervention than those with lower catastrophizing, and that psychological interventions specifically targeting catastrophizing, including pain neuroscience education and cognitive behavioral therapy, improve outcomes independently of the physical treatments applied. Pain neuroscience education, the structured provision of accurate information about how pain works at the neurological level, how central sensitization amplifies pain perception, and how pain is not simply a direct readout of tissue damage, has been documented in multiple randomized controlled trials to reduce pain catastrophizing, improve pain self-efficacy, and improve functional outcomes in adults with chronic musculoskeletal pain, including knee osteoarthritis. This video and the others in this arthritis series constitute a form of pain neuroscience education that directly addresses the beliefs and expectations that determine how effectively every other treatment works. Sleep quality is equally important and equally underaddressed. Poor sleep amplifies central sensitization, increases inflammatory cytokine production, and impairs the capacity for physical activity, the cornerstone of non-surgical management. The magnesium glycinate and tart cherry protocol we described in our bedtime video is simultaneously a sleep improvement intervention and a pain management intervention, and its integration into the complete non-surgical treatment program addresses a dimension that neither exercise programs nor injection therapies typically address. The concept of a personalized, staged non-surgical treatment plan is the framework within which all of these treatments are most effectively implemented. The typical staging begins with therapeutic exercise and weight management as universal first-line interventions for all grades of knee osteoarthritis, combined with topical NSAID for localized pain management. Physical therapy assessment is added in the first weeks to identify and address biomechanical deficits. Bracing and orthotics are added if medial compartment loading patterns are identified. Nutritional optimization is implemented concurrently and maintained throughout all subsequent stages. Intra-articular injection therapy is considered when the first-line program has been consistently implemented for at least 12 weeks without adequate improvement. And duloxetine is considered when central sensitization features are prominent and peripheral interventions have not produced adequate pain relief. This stage, personalized approach rather than the typical sequential trial of one treatment at a time, compresses the timeline from diagnosis to optimal treatment combination and produces the best outcomes before surgical referral becomes necessary. Surgery for knee osteoarthritis, total or partial knee replacement, is a genuine and often excellent solution for patients with severe end-stage disease who have failed comprehensive non-surgical management. But it is an intervention of last resort, not first resort. And the comprehensive non-surgical program, described in this video, is the medically appropriate path to attempt first systematically, completely, and with the understanding that the evidence supports its effectiveness strongly enough to justify the commitment it requires. Your knees deserve the complete toolkit, not one tool, not the two most convenient tools. The complete, evidence-based, multidimensional program that the research has built and that orthopedic and rehabilitation medicine now recognizes as the standard of care for knee arthritis before surgical intervention is considered. The evidence for acupuncture as a non-surgical treatment for knee osteoarthritis deserves specific mention because it occupies an interesting position in the evidence hierarchy. It has been the subject of numerous high-quality randomized controlled trials, and the honest interpretation of those trials reveals both genuine benefits and important limitations that every patient considering acupuncture for knee arthritis should understand. The largest and most rigorous meta-analysis of acupuncture for osteoarthritis pain, conducted by the Acupuncture Trialists Collaboration and published in the Journal of Pain, analyzed individual patient data from nearly 9,000 participants across multiple randomized, controlled trials and found that acupuncture produced statistically significant reductions in pain and improvements in function compared to both sham acupuncture and no acupuncture control groups. The effect sizes were modest, smaller than those seen with exercise therapy, but clinically meaningful and statistically robust. The mechanism through which acupuncture produces pain relief in knee osteoarthritis is still debated, but the proposed pathways include stimulation of descending pain inhibitory pathways through the periaqueductal gray matter, promotion of endogenous opioid release, modulation of inflammatory cytokine levels in the joint, and local effects on the fascial tissue surrounding the joint that may influence joint capsule mobility and proprioception. Whatever the precise mechanism, the clinical evidence is sufficient that the American College of Rheumatology includes acupuncture in its conditionally recommended treatments for knee osteoarthritis, meaning the evidence is positive, but not as strong as the strongly recommended treatments like exercise and weight management. For adults who have not responded adequately to exercise, weight management, physical therapy, and topical pharmacological management, acupuncture represents a reasonable adjunctive treatment with documented efficacy, a favorable safety profile, and a mechanism that does not overlap with any of the other non-surgical treatments in the program, meaning it can add benefit without competing with or duplicating existing interventions. Transcutaneous electrical nerve stimulation TENS represents another non-invasive, low-risk non-surgical option whose mechanism the delivery of electrical impulses through skin electrodes that activate peripheral sensory nerves and inhibit pain signal transmission through the gate control mechanism provides pain relief that is immediate, repeatable, and free of the systemic side effects of pharmacological management. The evidence base for TENS in knee osteoarthritis is positive but not as strong as for exercise or topical NSAIDs, and TENS is most appropriately positioned as an adjunct to the core program rather than a standalone treatment. Home TENS units are widely available and inexpensive, and they're used before exercise sessions, where the pre-exercise pain reduction can facilitate better quality and higher intensity exercise participation represents a particularly practical application. Heat and cold therapy. The application of heat packs or ice to the knee joint represent the most accessible and most underappreciated non-surgical pain management strategies in the knee arthritis toolkit. Heat applied to the knee joint for 15 to 20 minutes increases local blood flow, relaxes periarticular muscle tension, improves joint range of motion by reducing soft tissue viscosity, and reduces pain through the thermoreceptor-mediated pain inhibition pathways that compete with pain signal transmission in the dorsal horn. Cold applied after exercise or activity reduces acute post-exercise inflammation and swelling, decreases nerve conduction velocity in pain fibers, and provides the analgesic effect of cryotherapy that many athletes and rehabilitation specialists rely on for acute pain management. Neither heat nor cold therapy produces structural benefits for knee arthritis. They do not strengthen muscles, reduce body weight, or modify the inflammatory biology of the joint, but their capacity to reduce pain acutely and improve the tolerability of the exercise and physical activity that does produce structural benefits makes them genuinely valuable tools in the complete non-surgical toolkit, particularly for adults in the early phases of an exercise program when exercise-associated discomfort is at its highest. The concept of shared decision-making between the patient and the clinical team in non-surgical knee arthritis management deserves specific acknowledgement because the research on patient engagement and treatment adherence consistently finds that patients who understand their treatment rationale, who have participated in setting their treatment goals, and who feel genuine partnership with their care team show substantially higher adherence to therapeutic exercise programs and weight management interventions than those who have received treatments without adequate explanation or collaboration. The information in this video and across the entire arthritis series on this channel is designed to equip every adult with knee arthritis to participate in their care as an informed partner, to understand why exercise is more important than any medication, to understand why weight management produces biomechanical benefits that no injection can replicate, to understand the evidence hierarchy that ranks treatments from most to least supported, and to bring the understanding into every clinical encounter, asking the specific questions, requesting the specific assessments, and advocating for the specific components of the complete non-surgical program that the evidence supports and that too many patients never receive simply because they did not know to ask for them. You now have that knowledge. The conversation with your physician starts from a different place than it did before you watched this video. Use that difference. Your knees are depending on it. The role of assistive devices, walking aids including canes and walking poles in the non-surgical management of knee arthritis is frequently overlooked in favor of more dramatic interventions, but represents a simple, immediately accessible, and evidence-supported strategy for reducing knee joint loading during daily ambulation. A cane or walking stick used in the hand contralateral opposite to the affected knee reduces the knee adduction moment on the affected side by creating an external lateral force that counteracts the medial loading that drives medial compartment arthritis progression. Research has documented that cane use produces measurable reductions in knee adduction moments and subjective improvements in pain with walking in adults with medial compartment knee osteoarthritis. For adults whose pain primarily occurs during walking and who are not yet ready or able to implement the full exercise program, a cane used correctly in the opposite hand to the affected knee, with appropriate sizing so the elbow is slightly flexed, provides immediate mechanical load reduction that reduces pain during ambulation and facilitates the walking activity that the exercise program requires. Walking poles, the two-handed walking aids used in Nordic walking, distribute upper body weight through both arms, reducing the total lower extremity loading with each step and simultaneously engaging the upper body musculature in a way that increases the caloric expenditure and cardiovascular benefit of walking. Nordic walking for knee osteoarthritis has been studied in randomized controlled trials and found to produce significant improvements in pain and physical function compared to standard walking, with the mechanical unloading through the poles and the rhythmic upper body engagement producing benefits that extend beyond those of standard walking programs. The complete picture of non-surgical knee arthritis management, from the most fundamental interventions of exercise and weight management, through the targeted interventions of physical therapy, bracing, pharmacological management, and injection therapy, to the complementary interventions of acupuncture, TENS, heat and cold therapy, and assistive devices, and the foundational nutritional and psychological interventions that determine the effectiveness of everything else, is the most powerful toolkit available to adults who want to preserve their knee function, manage their pain, and live fully with this condition without surgical intervention. Every component has evidence. Every component has a mechanism. Every component addresses a dimension of knee arthritis that the others do not fully cover. And the complete program, applied systematically, maintained consistently, and monitored with the same attention to outcomes that you would bring to any medical treatment, produces results that to many adults with knee arthritis have never experienced because they have never been given the complete picture. You now have it, all of it. Use every part. If this video gave you the complete, evidence-based picture of non-surgical knee arthritis treatment that you have been looking for, please support this channel. Hit the like button right now. Subscribe if you have not already. Share this video with someone who has been told they might need knee surgery and has not yet received comprehensive non-surgical management. And leave a comment below. Tell us which of the treatments in this video you have tried, which you have not, and whether you are going to have a conversation with your physician about the ones that are missing from your current plan. We read every comment. Your engagement makes this channel possible and this content available to the people who need it most. Thank you so much for watching. See you in the next one.